video is an introduction to cholinergic neurotransmission. In this episode, we will cover the synthesis, storage and release of acetylcholine, the binding of acetylcholine to various types of cholinergic receptors, the actions of acetylcholine as a neurotransmitter, and the degradation of acetylcholine with the help of cholinesterase enzymes, and lastly, the drugs that inhibit cholinergic transmission and the uses of these drugs. In my earlier videos, we have learned that the parasympathetic preganglionic fibers emerge from the cranial and the sacral regions of the central nervous system. The cranial outflow is carried out by the 3rd, 7th, 9th and 10th nerve, and the sacral outflow is carried out by the 2nd, 3rd and 4th sacral segments of the spinal cord, hence designated as craniosacral outflow. In this figure, we can see that the parasympathetic nerve fibers of the 3rd cranial nerve that innervate the circular muscle of the iris and the ciliary muscle of the eye. The 7th or the facial nerve innervates the glands, namely the lacrimal glands, nasal glands, palatine, sublingual glands and submandibular glands. So salivary glands and lacrimal glands are innervated by the 7th nerve. The 9th or the glossopharyngeal nerve innervates the parotid gland, which is responsible for salivary secretion. The 10th or the vagal nerve innervates the heart, the GI tract, smooth muscle, gastric glands, lungs and kidney. The sacral outflow supplies to the large intestine, external genitalia and the urinary bladder. Most organ systems have dual innervation, that is, they are innervated by the sympathetic and parasympathetic nerves. The sympathetic nervous system dominates at some sites and the parasympathetic nervous system dominates at the other sites. This table shows the blood vessels, namely the arterioles and the veins, have predominant sympathetic nerve supply. The heart is predominantly innervated by the parasympathetic neurons. In the eye, the radial muscle of the iris has sympathetic innervation, while the sphincter muscle of the iris and the ciliary muscle of the eye have parasympathetic innervation. The smooth muscles such as the bronchial smooth muscles, GI tract smooth muscles, urinary tract and salivary glands are predominantly innervated by the parasympathetic nerves. Next, how is acetylcholine synthesized, stored, released and acts on various receptors? The steps in the biosynthesis of acetylcholine. Acetylcholine is synthesized in the axon terminal from choline and acetyl coenzyme A, and the step is catalyzed by the enzyme choline acetyl transferase. Choline is highly polar and actively transported into the axoplasm or into the cytoplasm of the nerve terminal by a high affinity sodium dependent transporter. So the transporter is responsible for the transport of choline, which is highly polar, into the cytoplasm of the nerve terminals. The acetyl coenzyme A, which is a precursor for the synthesis of acetylcholine, is synthesized in the mitochondria from pyruvate in the presence of an enzyme that is pyruvate dehydrogenase. Acetyl coenzyme A is then transported out of the mitochondria into the cytoplasm by an unknown process. Now acetyl coenzyme A combines with choline in presence of an enzyme that is choline acetyl transferase and forms acetylcholine. The next step is storage. The acetylcholine that is formed in the cytoplasm of the nerve terminal is taken up, stored and concentrated in the storage vesicle in the presence of a transporter called the vesicle associated transporter. The vesicular transport allows the uptake of acetylcholine into the vesicle and is ATP dependent. This active vesicular uptake of acetylcholine is selectively blocked by vesamicol, inhibiting the storage of acetylcholine, resulting in slowly depolarizing neuromuscular block. The next step, the release of acetylcholine into the synaptic cleft. The arrival of an action potential leads to an influx of calcium ions which triggers the release of acetylcholine by exocytosis. The exocytosis mechanism involves an interaction between the proteins associated with the vesicle, that is synaptobravin, and the nerve-ending proteins, that is syntaxin. So the interaction between the vesicular protein, that is synaptobravin, and the neuronal protein, that is syntaxin, results in the fusion of the vesicle and the nerve ending, resulting in the opening of a pore towards the extracellular space and the release of acetylcholine. Botulinum toxin enzymatically alters synaptobravin to prevent the release of acetylcholine from all cholinergic fibers. The transmitter release, which requires nerve action potential through calcium entry, is prevented by local anesthetics and tetrodotoxin. The next step is binding to the receptor. At the postsynaptic effector cell membrane, acetylcholine reacts with its receptors, that is muscarinic receptors and nicotinic receptors, to produce respective cholinergic actions. So what are the different types of cholinergic receptors? The cholinergic receptors are divided into nicotinic receptors and muscarinic receptors. The nicotinic receptors are divided into two subtypes, that is the NM or nicotinic muscle type of receptor and NN, that is nicotinic neuronal type of receptor. The nicotinic receptors are ionotropic or ligand-gated receptors because they allow the passage of ions. The structure of nicotinic receptor consists of 5 subunits, 2 alpha subunits, beta, delta and gamma subunits. Acetylcholine binding site is present between alpha and gamma subunit, and the second acetylcholine binding site is located between the alpha and the delta subunit. Alpha subunit has projections which close the lumen. When acetylcholine binds to the alpha subunits, the projections move towards the alpha subunit, opening the lumen and allowing the movement of sodium through the lumen, causing depolarization and generation of end plate potential. When the end plate potential reaches the threshold, there is firing of the action potential and muscular contraction. The nicotinic receptors are of two subtypes, the NM or the muscle type nicotinic receptor, which is present in the neuromuscular junction. It is postsynaptic in nature, and stimulation of the NM receptors of the neuromuscular junction by acetylcholine causes contraction of the skeletal muscle. These are ligand-gated ion channels which allow the passage of sodium ions, causing depolarization and contraction of the skeletal muscle. The next subtype is NN or neuronal type nicotinic receptors that are found in all autonomic ganglia and the adrenal medulla. Stimulation of NN receptors in the autonomic ganglia help in the transmission of impulses from the preganglionic nerve fibers to the postganglionic nerve fibers and firing of the impulses. Stimulation of NN receptors in the adrenal medulla result in the release of epinephrine and norepinephrine from the adrenal medulla and increase the sympathetic neurotransmission. Both NM and NN receptors are ligand-gated ion channels or ionotropic receptors and allow the passage of ions, that is sodium ions. The central nicotinic receptors are present in the brain. They are present presynaptically and facilitate the release of dopamine and glutamate. The next type of cholinergic receptor is muscarinic receptors. The muscarinic receptors are of 5 subtypes, M1, M2, M3, 4 and 5. The odd-numbered muscarinic receptors, that is M1, M3 and M5, are excitatory in nature and coupled to GQ protein, resulting in activation of the phospholipase C IP3-DAG pathway, increasing the release of calcium and thereby producing their actions. M2 and M4 are inhibitory in nature. They associate with GI protein or G inhibitory protein and decrease the cyclic AMP formation and produce a therapeutic effect. Among these receptors, M1, M2 and M3 are well characterized. In terms of location of these receptors, The M1 receptors are located in the autonomic ganglia and the gastric tissue. So stimulation of M1 receptors produce excitatory effects and they increase the gastric acid secretion and also increase the GI motility by increasing the gastric smooth muscle contraction. Antagonists of M1 receptors are pyranzepine and telenzepine. M2 receptors are cardiac in nature and are mostly located in the myocardium of the heart and on the presynaptic terminals of the peripheral and central neurons. Activation of M2 receptors causes vagal inhibition of the heart, decreasing the heart rate and conductivity. The M2 receptors present in the presynaptic nerve endings inhibit the release of acetylcholine, decreasing the cholinergic neurotransmission. The antagonist to M2 receptor is tryptamine and galamine. The next subtype of muscarinic receptor is M3 muscarinic receptors. They are present in the smooth muscles and glands. Stimulation of M3 receptors in the smooth muscles and glands causes contraction of the smooth muscles and increases the glandular secretions. M3 receptors are also present in the endothelium of the blood vessels, and stimulation of M3 receptors of the blood vessels releases nitric oxide, causing relaxation of the vascular smooth muscle and vasodilatation of the blood vessels. The next step is metabolism and termination of action of acetylcholine. Acetylcholine is hydrolyzed by an enzyme called acetylcholinesterase to choline and acetic acid, and thus the actions of acetylcholine are terminated. Choline is taken up by the presynaptic nerve ending by the choline transporter. So the choline transport acts as a rate limiting step in acetylcholine biosynthesis and regulates the release of acetylcholine. The cholinesterase enzyme, which is responsible for the hydrolysis of acetylcholine, is of two types. The true acetylcholine esterase, which is a membrane bound enzyme present in the neuronal membrane, the cholinergic synaptic cleft, and to a small extent in RBC and placenta. It is highly specific in hydrolyzing acetylcholine and other acetyl esters, example methacholine. But to be remembered that it does not hydrolyze succinylcholine, butyrylcholine or benzoylcholine. The second type of cholinesterase enzyme, that is the pseudocholinesterase or butyrylcholinesterase enzyme, is synthesized in the liver and is found predominantly in plasma and also in the intestine. Its actions are non-specific as it hydrolyzes succinylcholine, benzoylcholine and butyrylcholine esters more easily than acetylcholine and acetylcholine esters. Secondly, genetic variations are commonly seen with this enzyme because some people have atypical pseudocholinesterase enzyme that results in slow hydrolysis of cholinomimetic drug, that is succinylcholine, which is a neuromuscular blocker. This results in the prolongation of action of succinylcholine, resulting in apnea. So what are the drugs acting at various steps of synthesis, storage and release of acetylcholine? The drugs are hemicolinium, which is similar to choline, blocks the uptake of choline by action on the presynaptic neuron, and this is used in animal experiments. The second drug is vesamicol, which blocks the uptake of acetylcholine by the vesicle, and this is also used in animal experiments. The third drug, aminoglycosides, block presynaptic calcium channels and produce neuromuscular toxicity. Fourth, bungarotoxins or botulinum toxins block acetylcholine release and cause botulism. Due to absence of acetylcholine release, the muscles don't contract and this results in respiratory failure. The muscle tone is lost and this can cause floppy infant syndrome. So what are the therapeutic uses of botulinum toxin? Botulinum toxin is used in achalasia, a disorder of the esophagus. It is also used to treat dystonia. It is used in cosmetology and used in migraine prophylaxis. These are my references. Thanks for watching. Please like, subscribe and share.